Hey, welcome everyone. I'm seeing a few people have started entering the room. So welcome to the Human Services and Justice Coordinating Committee, HSJCC conference. And at this first session, A1, entitled Individual Journey, Mental Health and Addiction in Provincial Corrections. So my name is Zamin Fazal, and I'm joined by my colleague here, Sarah Fruckman. We will be both your moderators for this session. Before we get started, you can get comfortable, grab a glass of water or juice, anything to keep you hydrated. It's a nice weather outside here in Ontario where I am. I'm not sure how it is from your side. So before we get started, I will review some quick housekeeping notes, and then I will introduce our speakers and begin the session. I would like to draw your attention to the bottom of your screen. You can use the chat feature to submit questions. Please type a question in big capital letters before submitting your question in the chat to make it easier for us to find them. The presenters will be taking questions at the end of their presentation. We'll have a quick Q&A session. We will do our best to ask as many questions and respond to as many questions as possible we can during the time we have. Please ensure your microphone is on mute until the Q&A portion of the session has started. Please note that we will be recording this session to upload to the conference website for future viewing by those who have registered for the conference. You will be able to access the platform for 90 days following the conference. Also, we please kindly ask you to complete a short evaluation at the end of the session. There'll be a couple of minutes reserved for that. Your feedback is much appreciated and will be used to inform future events such as this conference. And lastly, we would like to respectfully ask all of those attending to this session to engage with each other thoughtfully and always consider the impact of your words and interactions on others. As moderators, we will not tolerate abusive or inappropriate behavior, and we will ensure that anyone who engages in such behavior is removed from this session. So I would like to now introduce you to the two presenters we have today for this session. I have Eric Sabiti, who is from the Correctional Services with the Ministry of Solicitor General. And I have also Teresa Berry with us, who is also from the Correctional Services with the Ministry of Solicitor General. So without further ado, I would like ask Teresa, Eric, I think is starting to take over from here. Thank you.
Thanks, moderators, and appreciate the warm welcome. Hello, everyone, and thank you for joining in our session today and in an individual's journey with mental health and addictions and provincial corrections. Again, my name is Eric Sabiti, and I'm a senior program advisor with the Mental Health and Addictions Unit at the Ministry of the Solicitor General. I've been with the ministry since April 2021, previously worked at the Ministry of Health during the pandemic in the child and youth mental health portfolio. And I began my career in the Ontario Public Service in 2015 at the Ministry of Children, Community and Social Services with the Ontario Disability Support Program. So in case you're not sure of the Ministry of the Solicitor General, or what we refer to as SOLGEN in our presentation, in a nutshell, we are responsible for the public and community safety, policing, corrections, and animal welfare across the province of Ontario. So of course, we'll be focusing a lot of our attention on the corrections side today. Here with me, we have Teresa on my team to introduce herself, and we also have Joanna that will help us through the slides. So please, Teresa, go ahead.
Thanks, Eric. Hi, everyone. Teresa Berry, Senior Policy and Program Analyst in the Mental Health and Addiction Unit of the Ministry of Solicitor General. I'm happy to be here. I've been in this role for about 2.5 years. I'm also a social worker, and prior to being in this role, I worked at Maplehurst, working in the institution as a social worker there. And I also worked at Ministry of Children and Youth at the Roy McMurtry Youth Centre in Brampton. So just happy to be here and presenting today to you all. Back to you, Eric.
Thanks. So Joanna, we're going to go to the website. Thank you. So this presentation will cover some of our new established health services division, which would include our corporate healthcare and wellness branch. And in that, we have the mental health and addictions unit, which is our unit. We'll look at some of the context in the snapshot of Ontario Corrections. We'll also look at the the Corrections mental health and addiction strategy for individuals in custody and under community supervision in Ontario. We'll look at an individual's journey in Ontario Corrections with mental health and addictions needs. So from admissions to screening, assessment, treatment, and reintegration. After that, we'll look at some of our future considerations to address mental health and addictions and corrections. And finally, we'll go through some questions you may have and share our contact information. So our health services division, which it does include our corporate healthcare and wellness branch, we provided an organizational chart here with an overview of the corporate healthcare and wellness branch and the newly established health services division and the 7 units within our branch, including the mental health and addictions unit. So our corporate healthcare and wellness branch is responsible for the strategic planning, delivery, and evaluation of policy and program strategies that support the delivery of whole healthcare services within correctional facilities across the province. So the 7 units from left to right. So from left, we have our corporate healthcare unit that provides oversight of primary healthcare services for individuals in custody. We have our digital health systems unit that has oversight of digital health initiatives, including moving health records in institutions to electronic medical records. Our employee wellness unit has oversight of employee wellness supports and programs for frontline staff and correctional services. Well, that includes stress resilience and mindfulness program, along with the peer support program for frontline staff. We have our healthcare planning and performance that ensures there are appropriate performance indicators associated to our initiatives and are supported by appropriate healthcare human resources. Our mental health secretariat has oversight over frontline public safety, personal wellness, and resilience supports for Ontario Provincial Police, Fire Marshal, Coroner's Office, and Correctional Services in collaboration with Employee Wellness Unit. And finally, the Infection Prevention and Control Unit has oversight of infection prevention and control protocols within institutional and community services. Sorry, I'm just getting over a cold here. And now our mental health and addictions unit is just over 3 years old and is comprised of a manager, 2 senior program advisors, so Joanna and myself, 2 senior program analysts, a senior social work and special needs consultant, and a senior psychology consultant. So one of the 2 senior program analysts is Teresa, that's on the call with us today. Our unit is responsible for the oversight. Sorry. I'm just getting over. Our unit is responsible for oversight of our mental health and addiction strategy for corrections, including institutional and community services, ensuring greater continuity of care through enhanced community partnerships, enabling our clients equal access to services, and building a collaborative approach that serves to improve the delivery of care to our clients. Next slide. So here we'll look at some of the context in Ontario Corrections right now. We have over 80% of those in Ontario Correctional institutions are on remand, so which basically means that they have not completed trial and sentencing process. In 2021, the median number of days spent in custody on remand was 21 days, and the median provincial sentence in Ontario in 2021 was 24 days. So a lot of these individuals are not in our institutions for a long period of time. There are various estimates on the prevalence of mental illnesses in the correction system. Individuals in custody have higher rates of developmental disabilities, including fetal alcohol spectrum disorder and acquired brain injury. The snapshot of the offender tracking information system, which we refer to as OTIS, data indicates that over 20% of individuals in Ontario correctional institutions have a verified mental health alert and 48% have a substance use alert. In 2020-21, the Indigenous incarceration rate in Ontario was 6.3 times higher than non-Indigenous incarceration rate. Indigenous women's incarceration rate is 12.5 times higher compared to non-Indigenous women. Women in custody experience higher rates of traumatic experiences, histories, and violence, self-harming behavior, hepatitis C virus or HCV, mental illness, and substance use disorder. Within the first 6 days after release from a correctional institution, these individuals are hospitalized at a psychiatric facility 58 times more than the general population, and 12 times more at 1 to 3 months after release. Next slide. So as part of our mental health and addiction strategy, here are some of our short-term outcomes we've made progress on thus far. So in terms of data collection, we've improved mental health and addiction data utilization to influence evidence-based decision-making and accountability, such as developing acute care stabilization continuum of care data collection survey to gather the effectiveness of this program. And we will get into what acute care stabilization is later on in this presentation. We gather mental health alerts and institutional snapshots, so looking at people who are sentenced versus remand on an ongoing basis. These efforts are all to gather, analyze, and make necessary improvements within our correctional facilities. So in terms of interprofessional teams, we've established mental health and addictions interprofessional teams through the hiring of 57 addiction counselors across the province of Ontario. In terms of communication, we've improved communication to facilitate the provision of high quality mental health and addiction services, where we have regular community of practice meetings with stakeholders, check-ins with our ministry and hospital partners. In terms of care pathways, we have established a mental health and addictions care pathways that includes the Center for Addiction and Mental Health as Forensic Early Intervention Services model, which also we refer to as FEIS, deployed at the Toronto South Detention Center and Banning Center for Women, that provides early detection for individuals in custody with a serious mental illness who may be at risk of being unfit to stand trial or at the beginning of a trajectory that could result in a finding of not criminally responsible on account of mental disorder. Teresa will elaborate more on the screening tools after this slide. In terms of health equity, we've improved access to care that is trauma-informed, gender-safe, culturally safe, by establishing a trauma-informed working group, and we place a lot of priority on improving the mental health of women in custody. Those are some of our short-term outcomes. Some of our intermediate outcomes includes, but not limited to, improving the continuum of care during access and transition points within the justice system. We've increased diversion from incarceration. We want better monitoring, evaluation, accountability, and governance of mental health and addiction services. And some of our long-term outcomes include just the overall mental health and well-being of justice-involved individuals. We want reduced costs by early intervention, so programs like I mentioned before, like FEIS, and decreased use of emergency services. We want seamless continuum of care and partnership across ministries and community agencies. And overall, we want to reduce the rates of recidivism. I'll now pass it over to my colleague, Teresa, to discuss an individual's journey in Ontario Corrections.
Thanks, Eric. So now that we've heard about some of the things that SolGen is working on and learned about the context, some of the context pieces in Ontario Corrections, now we'll shift over to a case example of what an individual's journey might look like in the Ontario Correctional System. So I'd like to introduce Client A, who is a 25-year-old individual admitted to Hamilton Wentworth Detention Center on a remand warrant for assault with a weapon. This is Client A's first time in custody, and they have no previous criminal justice involvement. While in admittance and discharge, or A&D, Client A was observed to be responding to auditory hallucinations. When staff approached the cell, Client A became verbally agitated and hostile towards staff. Client A was punching the door and walls when staff were observing them. Their hand was bleeding heavily and requires medical attention. Staff note that Client A seems to be religiously preoccupied and has written scripture on the walls of the cell. So this is a flow chart we've got to kind of explain some of the processes that client A will be going through. So client A has been admitted to Hamilton Wentworth Detention Center. While in A&D, the nurse will interview client A to complete all sections of the healthcare record. Healthcare staff will be busy requesting pertinent records from the patient's community pharmacy, healthcare providers, and other service agencies, trying to get as much information as they can about this person. Client A will be asked to sign a consent to the disclosure of personal health information form. The nurse in A&D will be assessing client A for the presence of acute mental health illness and impaired functioning. Be looking at psychiatric history, including any admissions to a psychiatric hospital or outpatient treatment, current or recent psychiatric medications prescribed in the community, and their adherence to treatment if they have any of that information. The nurse is going to be assessing for past or present suicidal ideation or attempts at self-harming behavior. And this nursing assessment needs to be completed within 48 hours of client A's admission. I'd also like to talk a little bit about the Take Home Naloxone program. At the time of admission, the nurse will ask client A about opioid use in addition to other substances and alcohol. If client A reports opioid use, the nurse will offer the patient the opportunity to obtain a take-home naloxone kit. If client A accepts it, arrangements will be made to provide health teaching to the client and to provide the kit in their personal property. If client A declines the kit, health teaching will still be provided regarding loss of tolerance and risk of overdose while in custody and after custody. Part of the nurse's assessment includes the brief jail mental health screen, and we'll go to the next slide to look at that screening tool in more detail. So this is the top portion of the brief jail mental health screen, or BJMHS. It's a quick, effective tool used by nurses in A&D to screen the incoming client A or patient A at the detention center and checking for the need for further mental health assessment. The BJMHS assesses for the possibility of having a serious mental illness, such as schizophrenia, bipolar disorder, or major depression. The process takes less than 3 minutes. The entire screen consists of only 8 yes or no questions, which you can see here on the slide. You can see that the nurse completing the BJMHS with client A wasn't able to fully engage with them, noting in the comments that the patient either didn't respond to the questions or wasn't able to. The nurse also commented that patient A appeared to be responding to auditory hallucinations. And we'll go to the next slide to see the bottom portion of the BJMHS. So you can see here under comments and impressions, the nurse is able to identify quickly by checking the appropriate boxes if the patient had a language barrier, difficulty understanding questions, is under the influence of drugs or alcohol, or are non-cooperative. So based on the BJMHS, client A has screened positive and will be referred to the mental health team for further mental health assessment. So we'll go back to the next slide, which shows our referral pathway. So the client A has been admitted to Hamilton Wentworth Detention Center. The nurse has now completed the nursing assessment, including the BJMHS for client A. And they are being referred to the social worker at Hamilton Wentworth Detention Center to complete the jail screening assessment tool, or JSAT. So along with the nursing assessment, as soon as possible after admission, the primary care physician or nurse practitioner also conducts their own health assessment with patient A and completes the primary care admission assessment, which outlines an individualized treatment plan, including immediate and long-term treatment needs, prescribes any necessary medication and treatment, order or performs diagnostic investigations where clinically indicated, encourages testing for sexually transmitted infections and bloodborne infections if needed. They outline any restrictions in activity or participation in institutional programming, and they'll make any necessary referrals, such as for psychiatric services and assessment, treatment, counseling services, community health specialists or practitioners in the community, and dental services for the immediate relief of pain and infection. So now we'll go to the next slide to take a closer look at the JSAT. So this is the top portion of the Jail Screening Assessment Tool, or JSAT coding form. And because a comprehensive psychological assessment of every individual entering every correctional institution is inefficient and unfeasible, the JSAT is designed to identify individuals who require mental health services and refer these individuals to a mental health professional for further evaluation. The number of individuals that need to be screened varies considerably between different locations, different institutions. And just for context, the average number of daily admits at the Hamilton Wentworth Detention Center is around 12. So you can understand that because the rates of admission are varied and sometimes quite a lot of volume of folks coming in and out, we don't do the JSAT on every single individual. But as we saw, client A was screened positive, so the social worker is going to be completing the JSAT with this individual. And the JSAT interview needs to take place as soon as possible after referral, but no later than 96 hours following admission. And you can see on this JSAT form for client A that the interview date was 1 day after they were admitted to the institution. And along with identifying individuals who require mental health services upon admit to custody and quickly referring these individuals for treatment and care, the JSAT is also designed to prevent violence against self and others and disruptive incidents in correctional institutions. You can see on this portion of the JSAT form under the violence issues section, that the social worker is asking client A about past aggression or violence. And they may also be looking at the Offender Tracking and Information System, or OTIS, to check if client A has any past violent offenses or incidences while in custody. You may recall that this is client A's first time involved with the criminal justice system, so the social worker has ticked no there. However, the social worker learned from staff that client A was aggressive and punching cell walls during the admittance process, and has indicated that yes, there are violence issues to be aware of for this client. We'll go to the next slide to see another portion of the JSAT. So the social worker at Hamilton Wentworth Detention Center is also using the JSAT interview, which takes on average just under 20 minutes with client A to assess his current level of functioning and to predict an expected level of psychological adjustment within the institution. This is his first time in custody, so it's important to assess how they think this individual is going to function while they're in the institution. On this slide, you can see that the social worker has asked client A about their past and present mental health treatment history, along with history of suicidality, but wasn't able to fully complete the form in each section, as client A was not responding to questions and unable to fully engage in the interview. Go to the next slide to see the last portion of the JSAT. So another purpose of the JSAT is to make recommendations to correctional staff regarding placement, crisis intervention, and treatment of individuals. You'll see here on the bottom portion of the JSAT form that the social worker has made a placement recommendation for client A to be housed on the Managed Clinical Care or Stabilization Unit of Hamilton Wentworth Detention Center. The social worker has made the comment at the bottom that client A presented with symptoms of active psychosis and appeared to be responding to auditory hallucinations throughout the interview. The need for interdisciplinary consultation is highlighted with the social worker's comment that staff shared with her that the client was punching doors and walls of the cell while in A&D. Interdisciplinary consultation increases the likelihood that all relevant issues will be taken into consideration when making management and placement recommendations for client A, who was referred to the psychiatrist and mental health team for services to discuss a possible referral to an acute care stabilization bed. And I'll now pass it over back to Eric to explain a little bit more about these ACS beds.
Thanks, Teresa. So you could see that client A has gone from admissions to screening, and now it's time for the treatment. So where the treatment is where we have the acute care stabilization beds. So ACS beds are collaborative mental health initiatives between Solgen and the Ministry of Health that provides short-term, normally up to 90 days, inpatient psychiatric care in a secure forensic mental health setting, which is a designated hospital, to acutely ill incarcerated individuals whose symptoms are too complex for general hospitals. To be eligible, you must meet the following 4 criteria. So 1, you must present with a severe and persistent mental illness with significant impairment. 2, require more intensive treatment than is available at the correctional facility or detention center. 3, you must be capable of making treatment decisions and consenting to receiving treatment. However, note that there are further criteria and steps involved if the person is deemed incapable of providing consent and may be referred to the Capacity and Consent Board. 4, and probably the most important, you must be formable under the provisions of the Mental Health Act. Placing someone on a Form 1 means that the assessing physician or psychiatrist must reasonably believe that that person is at risk of self-harm, harm to others, and or is unable to care for themselves without psychiatric treatment, such that it would cause them serious physical impairment without intervention. The Form 1 allows a physician or psychiatrist to detain a patient for psychiatric assessment for up to 72 hours at a Schedule 1 facility, which is a designated psychiatric facility under the Mental Health Act. Once the form is signed, it is effective for 7 days and provides authority to transfer that individual to a psychiatric facility where they'll be detained, restrained, observed, and examined for no more than 72 hours. Next slide. So here we look at the client A's pathway. So the referral began where staff at Hamilton Wentworth Detention Center flagged client A as a new referral at a joint clinical meeting. The coordinator completes the admission forms, collaborating with both St. Joseph's Hospital in Hamilton and Hamilton Wentworth Detention Center staff. The coordinator secures the transfer date, time, and communicates these details with Hamilton Wentworth Detention Center mental health nurses. The coordinator informs all relevant staff, so whether it's a Hamilton Wentworth physician, managers, team lead, about the details of the transfer. The client A is then transferred from Hamilton Wentworth Detention Center to St. Joe's ACS bed via a Solgen vehicle. In terms of admission, Hamilton Wentworth Detention Center staff will provide verbal report to a coordinator with any significant clinical changes regarding this client. The ACS bed treatment team will review admission form and completes St. Joseph's admission documentation. Here, client A is then provided treatment for 10 days or approximate duration until their condition improves. Once that condition is improved, we can now look at discharging this client, and then client A has then been deemed appropriate for discharge by the St. Joe's treatment team. The coordinator confirms the transfer date with the Hamilton Wentworth Detention Center mental health nurses. The ACS bed treatment team completes discharge summary and required documentation. The client A is then transferred from St. Joe's bed to Hamilton Wentworth, again, via a Solgen vehicle, where they're now in a stable condition. I will now pass it over to Teresa to discuss interdisciplinary care planning.
Thanks, Eric. So as I mentioned earlier, the benefits of consulting with the interdisciplinary team cannot be overstated. Client A has returned to Hamilton Wentworth Detention Center from their stay in the ACS bed at St. Joe's, and they've stabilized. But mental health is fluid, and continual monitoring for changes in client A's mental health status is the responsibility of all staff. The interprofessional team is comprised of different professionals and occupations with varied and specialized knowledge and different skills. Depending on the resources of each institution, a team may include mental health providers, clinical staff, correctional officers, and program staff such as classification officers, addiction counselors, rehabilitative officers, Native Inmate Liaison officers, or NILOs, elders, and any other relevant staff. And we'll go to the next slide to look at the the document that the interprofessional team is going to use for client A. So this is part of the inmate care plan, which is a document that the team uses to facilitate client A's rehabilitation and treatment. A care plan is a written document initiated for those individuals that require specialized care or support. The care plan should not include any confidential information that is subject to PHIPAA, Personal Health Information and Privacy Act. However, information such as observations, symptoms, and compliance or non-compliance with medication should be shared where relevant. A care plan may be initiated by any member of the interprofessional team. For client A, the social worker that completed the JSAT with him also initiated a care plan that same day prior to them going to St. Joe's ACS bed. This is meeting the required timeline, as once it is determined that a care plan is required, it will be initiated within 48 hours during normal business hours or 72 hours if made during weekends or holidays. Now we'll go to the next slide to see another part of the care plan document. Once the care plan has been initiated, a collaborative process will take place through interprofessional meetings to ensure that information is included from all relevant program areas. If a staff member feels that the care plan should be reviewed sooner than the next available interprofessional team meeting, they may consult with the team as necessary. The operating manager in charge of the unit where client A is housed needs to be notified of the new care plan without any delay. You can see on this portion of the care plan document that there is a mental health and human rights checklist where the interprofessional team are discussing human rights code related needs for client A, including any accommodations they need and any other specific considerations, for example, religious, sex, gender identity or expression, sexual orientation, whether or not they're Indigenous, mental, physical, and developmental disabilities, faith, or etc. Care plans are living documents, and they must be placed in client A's living area where it will be accessible to staff and kept confidential from other individuals in custody. We'll go to the next slide. This is another part of the care plan document that was completed for client A. Included as part of the interprofessional team meetings, where a review of the care plan occurs, are discussion on management and care specific to client A within the limitations of the Personal Health and Information and Protection Act, or PHIPAA. They're discussing strategies on managing behavioral issues, for example, identifying triggers or de-escalation techniques. They're reviewing living unit options and strategies to remove client A from segregation conditions if applicable. They're looking at interventions or therapeutic options, for example, accessing an elder, arts and crafts, physical activity, reading and writing, relaxation and meditation, supportive conversation and engagement. They're also documenting any observed behavior of note, recommended programs and services, dietary needs, discharge planning and community reintegration, and any security measures recommended to mitigate risk. As part of the form, there's also additional operational considerations section of the care plan, where the multidisciplinary team records best practices for managing client A with details like routines, for example, showers, distribution of medication, yard time, recreation, some proposed meaningful social activities for staff-client contact beyond routines, frequency of time spent and interactions with clinical staff and the NILO, social activities with other individuals in custody, visits, telephone contact, access to news and information, and any volunteer programming recommendations. The care plan also includes an overview section where the social worker can enter details about client A's current state, behavior, strength, progress, and management goals. This creates a baseline for the interprofessional team to work from, and from there, the goals which the interprofessional team and client A would like to work towards are listed and are a source of information to support discharge planning. Now, I'll talk a little bit more about discharge planning with the next slide. So as you may recall, Client A was admitted to Hamilton Wentworth Detention Center on remand, as are over 80% of all those in custody in Ontario. And so his release date is unknown. He has an upcoming court date, and there is a possibility of release from court. The social worker at Hamilton Detention Center are working with Client A to complete the community reintegration and discharge planning form. Effective discharge planning and community reintegration begins at the time of admission, and it's a continual dynamic process as things change all the time. To ensure a safe transition at discharge, staff collaborate amongst the interprofessional team to develop a written discharge plan that includes some of the individualized aspects listed on this slide, also based on the community where the person plans to return to or go to. Staff are also making necessary referrals to community agencies and healthcare providers, establishing other community contacts or appointments for Client A. Healthcare staff facilitate and prepare a 3-day supply of medications or a bridging prescription, which are placed in Client A's property to ensure that they have access to medications upon release. For now, Client A remains at the Hamilton Wentworth Detention Center and is planning on going to court. However, his dynamic and changing discharge plan will be updated, and the interprofessional team have a discharge plan ready to go in case he is released at court. If you're interested in learning more about the community reintegration efforts in the Ministry of Solicitor General, I'd recommend you consider attending the concurrent session B3, Community Reintegration Planning Tables, being held today at 3 p.m. Now I'll pass it back to Eric, who can share some of our future considerations in the ministry.
Thanks, Teresa. So some of the future considerations to address our mental health and addictions and corrections include things like we want to continue looking at approaches to trauma-informed care. We're looking at expanding mindfulness programming for incarcerated individuals. We want ongoing engagement with community services and corrections, focusing on community reintegration. And Teresa makes a valid point there to attend the 3 p.m. session if you want to learn more about the community reintegration piece. We want enhanced suicide training and other learning opportunities for correctional staff. We also want continued collaboration with stakeholders and community partners on shared health and addiction priorities. And I think that brings us to an end of our presentation. Again, thank you for taking your time and joining us in today's session of an individual's journey in Ontario Corrections. We'll open up to any questions you may have, and if we cannot answer them, please take down our contact information, and we'll make sure to follow up with you. Thanks again.
I'm not seeing any questions in the chat. I just want to confirm that those in the audience haven't been typing in the chat and they've gone unnoticed. I know we've had a few tech issues this morning. Maybe I can start us off. Eric and Teresa, thank you so much for your presentation. There's so many people here listening. We've got over 100 people. Okay, great. We've got some questions going. Jennifer, why don't you take it away? You can ask yourself if you've got a question.
Hi, everybody. Thanks so much. It's easier to give context to the presenters. Anyways. So I'm a Crown in Brampton and I work in the drug treatment court. So we oftentimes have communication with Maplehurst and Vanier in particular. And I have two questions. One is, how does opioid replacement therapy work for people who are on remand, who are new into custody, but remain on remand, I should say? And is there a specific timeline that needs to be adhered to in order for them to access those medications that they were previously prescribed while they were in the community?
So you're sorry, just so I get your question clearly, you're wondering about opioid replacement therapy, and if they're already on it in the community and then they're coming into custody, and you're wondering about
timelines, I guess. Yeah, is there like a specific timeline that like the goal is to meet that timeline, or And I don't, I'm not trying to catch anyone off guard. The context of the question is we have many clients who are on those types of therapies go into custody, and we're getting reports that it's like up to a month before they can see a physician in order to continue to receive that medication. And they're obviously going through withdrawal while they're waiting for those types of therapies. So that's the context for my question. I'm just wondering how we can support them in our program.
Yeah, I can't speak to the specific wait times. I do know that the nurse is assessing as soon as people come in as part of the presentation, as part of their assessment, they're finding out and connecting with the community pharmacy as part of their nursing assessment within that 24, 48-hour period of,
Okay.
Was this person on, what was their dose, what prescriptions are they receiving? And they're on, as part of policy to be doing that right away, because we don't want people going through withdrawal unnecessarily.
Okay. Thank you. And I guess the second part of my question is, as part of the drug treatment court, we would like to have an ongoing communication with all of the institutions that our clients are at. Are there social workers the best point people to reach out to there in this, like, let's take the situation I just raised a moment ago. Would they be our best point of contact to perhaps assist the client in getting that meeting or that appointment?
As a social worker, I think we're great, but not every every institution is different. And so I wouldn't want to say like across the bar that, go to the social worker.
Right. Maybe I'll throw it out there.
If it's specific to, Maplehurst or specific to Vanier or whatever institution it is, we can get back to you about,
Sure.
And we'll reach out ourselves to institutional services and figure out who the best contact person might be. It might be the healthcare manager. I'm not sure exactly.
That would be really wonderful. I appreciate that. I'm going to leave my email in here, or I'll send you a message through the website as well. Thank you.
Best for you to send the message.
Yes.
Thank you so much, Jennifer, for your questions. We've got a lot of great questions. Lance is asking, is the 3 days of medication the standard for all inmates?
So that comes from policy, that 3-day amount of window, but it's not for every inmate. It might be a bridging prescription is the better way to go, depending on the medication. Like, I'm not a nurse, but because so many folks are on remand, we don't know when they're getting released. If we put 3 days of worth of medication in their property and then they don't get out and then it expires, or it's just there's problems with the unknown of the release date. So sometimes it'll be a bridging prescription that's put in there so that they have that in their property, but they can't just be putting, and it depending on the medication that it is.
Right. Thanks, Teresa. A few people are wondering, is this model to sort of mental health care and substance use in corrections, is it being applied to all correctional institutions in the province, or is it just being piloted at a few?
Well, the acute care stabilization beds is in 4 institutions. So it's Vanier, Toronto South, Hamilton, Wentworth, and Central East Correctional Facility. In terms of the actual brief, jail, and JSAT, Teresa, correct me if I'm wrong, but that's applied across all institutions when inmate is admitted there.
Okay, thanks, Eric. We've got a follow-up sort of to that question. When mental health in prisons is 5 to 7 times higher than community, how many acute care stabilization beds are available in community? And then I'll ask a separate question after.
So right now we actually have 13 beds in the Greater Toronto and Hamilton area. Of course, we are a brand new unit. I think I mentioned earlier, we're only 3 to 4 years old, the mental health and addictions unit, and we are always looking at opportunities to expand in other areas across the province. So right now there's only 13, but however, we are looking at opportunities for expansion.
Yeah, that's great. And L. Martin from Elizabeth Fry also asked, what gender-specific training is there for correctional staff regarding mental health supports? I know there was a lot in your presentation about the specific needs of women and gender diverse people.
So we've partnered with CAMH, the Center for Addiction and Mental Health, and they've worked with us to develop a tailored mental health training program. And it does involve different populations, including, gender specific issues that relate to mental health, along with the, in the context of corrections. So it's a very correction specific course that's available to all our staff.
Thanks, Teresa. Farhan is asking, when people are in custody for a short or long-term period, is there availability to take part in Narcotics Anonymous or Alcoholics Anonymous meetings virtually with the general public or with other inmates? Or perhaps there's one-to-one support in custody to help with their recovery? I guess the question is what sort of NA is available to those while they're inside correctional institutions?
I don't think there's any availability for virtual in custody. There's just not that capability to get on computers yet. But in terms of NA and AA meetings, those are regularly happening through the volunteer coordinator, and depending on the institution, they would be offered at the institution for folks to attend groups, and they might be able to meet with the person coming in that's a member of the organization individually, one-to-one. And we also have the addiction counselors that Eric mentioned. So we've hired 57 across the province. So there's addiction counselors in all our institutions, and they can work with the individual one-to-one or offer groups if that's part of the process, to really do a tailored recovery process for that individual.
Thanks, Teresa. Michelle Belmont asks, how is peer support used while in custody? And I imagine this is specifically related to sort of peer support when it comes to mental health issues while in corrections, but perhaps there are other peer support programs you could speak to.
So we have our employee wellness unit, and they have a peer support program that's for staff. So recognizing that when crisis happens in the institution or something, an individual employee needs support, having that peer that knows what it's like to work in that environment was you just recognized to be the better way to go. So we do have a very fulsome, comprehensive peer support program for staff. In terms of for the individuals in custody, there is a probation peer support program for individuals that have a substance use concern. I can't really provide a lot of the specifics about that. It happens when folks are on probation. At certain probation offices, it's offered. But if the individual wants to email me, I can definitely get them the information about that program.
All right, Michelle Belmont, send an email to Teresa. Another question from Jafina, and I think you talked a little bit about it, but maybe it just is worth clarifying, about access to medical files if an individual isn't able to communicate their health conditions and prescribed medication. Oh, Teresa, sorry, you're...
Oh, sorry, yeah, I'm sorry, I'm reading and I'm moving my mouth.
Oh, okay, yeah.
Is there access to medical files in case they are not able to communicate health conditions? I don't know if I'm understanding it.
So
is that sorry? Is that to access the acute care stabilization bed?
My understanding is this is the talk about medical history. So in the presentation, we talked about getting access to whether they had been sort of diagnosed with a psychiatric condition previously, whether they had been on medication.
Okay.
And so I guess sometimes an inmate may be in such distress, or perhaps they don't speak English very well and may not be able to communicate, to respond to the screener.
So the nurse is very busy during the admissions process, gathering as much information as they can. So they'll be contacting that person's doctor, pharmacy, any community agencies that can provide them with some information. And, you know, provided that they're in the circle of care, getting that information as soon as possible, just to get, you know, all the information required to be able to provide care while they're in custody. I hope that's answering it.
Yeah, I think that's maybe just explain what circle of care means, because I think it's a term of art that not everyone knows.
So let me put him on the spot here. It's so anybody that's providing that necessary, you know, health care for the individual is in the circle of care. That's maybe the best I can do there. That's not the best definition, but
I think it refers to, you have to be a designated health professional.
Right, sorry.
I was hoping you would have the, I encourage everyone to Google that. Neither Teresa nor I are, well, actually you're a social worker.
I am, but sorry. I'm removed from it for now.
Lance asks a great question to follow up on the number of acute care and stabilization beds available. If they're only in those 4 areas and there's only 13 of them, what are other institutions doing when there is an acute mental health case?
Well, I could take a quick stab at that. Teresa has worked frontline in the institution. So the other institutions do have what I refer to as those interprofessional teams, where again, we've hired those 57 addiction counselors across the province to provide the mental health and addiction services. We have mental health nurses, we have psychiatrists and things like that to help with those other institutions. And Teresa, if you want to add more to that.
Sure, yeah, every institution has, you know, psychiatry, nurse practitioners, all those folks that can respond if the person has acute mental health issues. If the person needs to be formed under the Mental Health Act and the institution doesn't have access to an ACS bed, they can, you know, access the hospital that's closest, and many psychiatrists at the institutions have relationships, and the institution healthcare team have relationships with those hospitals. Not to say that it's easy, but they can be formed in going into a hospital, a community hospital bed, as opposed to an ACS bed.
Thanks, Teresa and Eric. Joanne is asking, how can an outside mental health service get access to their clients while they're incarcerated? So, Joanne, if you mean this is someone who's already been connected with an outside mental health service and then they end up in custody and that point of connection and communication is cut off, is that I'm assuming that's what that means.
Yes, that's it.
Okay.
Yeah, I would say the social worker is a good bet there. When I was working in the institution, I would be working with, I see it from CMHA, you know, I would be contacting CMHA workers, especially if I knew that that person was connected with them in the community. So the social worker could get that person to sign a consent form, and then you connect with them that way. As a professional, you know, at different institutions, you would just need to, and the social worker would be able to explain this, how to come into the institution as a professional, if that's what you're interested in doing. So you could meet with your client in a professional visit. Getting on the phone is difficult at many institutions, so you might want to go through the social worker or come in yourself physically.
So Shaylee's question is a bit similar. So you've answered it partially, but maybe there's a couple other pieces we could flesh out. So Shaylee's asking, what is the best way for external services and supports to get in touch with staff? And you've recommended getting in touch with the social worker. With staff within the correctional institution and clients who are in custody, or sorry, for some reason I can't read that word. Oops. In order to be able to better assist with bail release and discharge planning, or even to provide information that could be useful as part of the care plan. Yeah, so I guess you've touched on it, but maybe when it comes to the transitions and care piece, and certainly it will be talked about in the community reintegration presentation.
I think it was pretty much answered.
Okay.
With yeah, thank you.
Okay, we've got just a few more minutes left, so add up your questions. L. Martin asks, is Solgen looking into expanding social, I assume SW social work and mental health, or social work and mental health access inside? I was just at Vanier, and the incarcerated persons speak to lag ties and barriers to these services.
Lag times, sorry.
Lag times, thank you. You can also ask the question yourself if you want.
Yeah, sure. Yeah, we just did the institutional inspection at Vanier and working through some of the IMATs and talking with each individual. You know, a lot of them spoke to lag times for services, specifically for social work and mental health access. So I'm just wondering if Solgen is looking to increase those services inside, because individuals really are struggling from that institution specifically.
Yes, thank you. I know that just like in hospitals, COVID has done a number on, you know, staff availability. So some folks have left. So there is staffing issues. That's always a concern, and that relates to a longer wait time, unfortunately, at different places. So I know that the ministry is busy working on strategies to, you know, hire more folks, making it more desirable to work at the institutions and things like that.
And just to add to that, Elizabeth, yes, so we continue to always look at improving mental health services inside institutions. So to put it simply as short and sweet, yes, we are looking into it. And again, we always seek those opportunities for funding to try to get that mental health access inside our institutions. So thank you for that.
We've got a question from Joanne. Oh, sorry, there was a question from Melissa before that. If clients are not released with medication or a bridging prescription, who is the best person to contact when contacting healthcare? They can sometimes provide a RX list, but pharmacies don't accept this. I guess.
Yeah, so I would call the line of the institution, and then ask to speak with the nurse, like the on-call nurse or the nurse that's working, especially if it's after hours, and have the pharmacy call the nurse directly, because they can confirm the medication. Because I know that the pharmacy can't accept just a list of medications. But if that was always the tip when I worked at Maplehurst, have the pharmacy call the institution directly, because then the nurse can share the information that way.
Okay, we have one more question and then we'll wrap it up. So Joanne is asking, have you developed a release from custody program, not CRPT, the red property bag program, for personal effects, medications, script for individuals being released at court, etc.?
I hope I'm not, it's in the works. We recognize that this is a big issue when people are released at court, and they're, maybe really far away from the institution. Maybe it's a Saturday or a Sunday, and their transportation's an issue. There's lots of issues there. So the red bag program is that, personal effects go with them to court, so that if they are released at court, they have at least their key, their meds, their script. So that is something that our unit is working on. Yes.
Thank you so much. Thanks everyone for your great questions, and thank you, Teresa and Eric, for answering them. I know sometimes these questions are challenging because you're doing your best to move a very large and complicated system. I'm going to pass it over to my colleague Zaman, to close us out.
Thank you, Sarah, for passing it over. Thank you, everyone, for having joined us in this session. So please join me to thank our speakers for this great presentation and for sharing their knowledge with us. Please take a few moments to complete the evaluation that I've just pasted in the chat room. The link can be found on the session description page. Thank you to our speakers and everyone who joined us today for all your insightful questions. We will now be taking a 60-minute lunch break to recharge. We also encourage you to use this time to connect with fellow participants, view poster presentations, or check out the several exhibitor booths that we have. And a reminder that we have some wonderful networking sessions, and please enjoy a pre-recorded mindfulness session that you'll find there. So enjoy your lunch until 1 p.m. and please join us back in this conference plenary for 1 p.m. for our keynote panel for the day one. It is called Highlighting Crisis Response Services and Models Across Ontario. You can join in a few minutes earlier, so to chat with your colleagues and to use the chat feature and just to get settled in, okay? So thank you very much, everyone. And on this note, we'll close the session. Thank you, everyone, for joining. Have a great rest of the afternoon.